I'm now going to move on to the final plenary of the day. It's called Vital for Improvement. How can we embed a culture of improvement and innovation, which follows on in many ways from what we were talking about with Margaret. The session is going to discuss improvement approaches, people sharing experience and learning from the NHS and beyond, the regulator's role in supporting improvement and innovation, and the importance of embedding a culture of improvement within organisations. And I'm delighted to welcome our panellists who've appeared by magic next to me. John Ashcroft, who's the Director of NHS Impact and Pathway Transformation for NHS England. Do you want to say hello? Mike Bracken, CBE, who's the founder of Public Digital. Penny Pereira, who is the Q Managing Director at the Health Foundation, and also James Benson, who's the Chief Executive Officer of Central London Community Healthcare NHS Trust. A reminder before they speak, we'll be taking questions from you. We have mics as ever, so raise your hands. And if you're watching online, you can submit your questions online too using Shake It. In fact, you can do it in the room if you don't want to ask a question yourself by scanning the QR code with your phones or tablets, and use the Q&A function if you're watching remotely. So I'm going to ask each of you to speak for about 5 minutes. There's a clock that you can watch to help you keep time, and after 5 minutes I'll let you know that you need to start wrapping, to give your opening reflections, and then we'll have a bit of a discussion going. So John Ashcroft first.
Right, so hi everyone. I can't see terribly well because of those lights, but does anybody know what a stringer is? So I learned what a stringer is this morning, and it is the underneath of a banister. And I learned about a stringer this morning because my 5-year-old ran full pelt into it and split his head open. And I was in an A&E trying to explain what he'd banged his head on, and was found that very difficult when someone told me that's what a stringer is. But in the space of 16 minutes, a little boy who was really, really upset with blood absolutely everywhere and a huge wound on his head had been treated, and I'd been treated, with such care, with such respect, that his head was glued up and he had a Superman sticker and felt very brave for heading off afterwards. So I just wanted to start, I wasn't where I was going to start this, but just thanking everyone here, because I think it's really easy to forget on a daily basis the amazing things that the NHS has done. And whilst I'll give my perspective as a National Director and a former Chief Executive of Hospital, as somebody who's experienced and received care today, I just want to say thank you to everyone because it was absolutely brilliant. So I'm going to talk a little bit about NHS Impact, improving patient care together. And hopefully most people will have heard about NHS Impact. It was launched in April by Amanda, following on from the Delivery of Continuous Improvement review. There's 5 core components of it. I'm not going to read through them on the screen. But what I am going to do is just talk about what's happened since April and what we're doing briefly going forward. So when Amanda launched it in April, we asked provider chief execs what they wanted, what would need to be true for them to embed continuous improvement in their organisation, and they told us a number of things. The one I want to focus on, probably the sort of top 2 on the slides, was about leading by example and NHC really setting the tone for this, and how important our role as an organisation is around that. As a former chief exec, I've been in an organisation that was rated CQC outstanding. I've been in an organisation that was rated requires improvement, and I do not underestimate the impact on staff and what that means, the pride people can have, the concern they have about the work they do every day and that really matters to them. So since April, we've done a number of things. We've launched NHS Impact. We've shared a self-assessment that people said they wanted, a baseline for improvement. We've had really, really strong engagement with that. So in terms of the baseline for improvement, every national team, every regional team, every ICB, and about 80% of providers return that to us, so really strong engagement and uptake for that. We've established a National Improvement Board, which I'll talk a little bit more about in a second. We've been working really closely with NHS England's Management and Leadership Development Programme, and earlier this month, we had our first session for new non-execs and chairs. And I was absolutely delighted that we had an hour-long session on continuous improvement and leading for improvement and what that really means for a board in there. And going back to the feedback that we'd heard previously about NHC changing the way we operate and sort of going on this journey, which Amanda's really publicly committed to on a number of occasions, we have begun going on that journey because we recognise we need to. We had a half-day workshop with the executive. We were talking about what we need to do, not in terms of how we deal with and engage necessarily with providers in the first instance, but how we as an organisation need to improve and go on this journey ourselves and where the waste is in our organisation. So the National Improvement Board met for the first time in September. You'll see the members of it on the screen behind you. I'm delighted we've appointed David Fillingham, Professor Andy Hardy and Elsa Brunton through open competitive processes. We are hoping to announce who the National Clinical Director is imminently. The board meets on a monthly basis and we've met 3 times now. Nice to see some really great people, great individuals on it, and really importantly, I think representation from provider organisations as well. So our first or second meeting, we talked about our priorities and what we are going to do. So they're set out on the screen. Behind us, we've got a longer session in December where we're going to talk in a little bit more detail and come up with a plan that we'll communicate about each of them. And I think we're really, really keen that NHS Impact, you know, it is about inspiring rather than instructing. We recognise that NHS England has to go on this journey alongside everyone that we're asking them to go on. We recognise that everyone is in a different place around this. But fundamentally, I think going back to where I started, everybody is going to work to do the best they can, do the right thing for patients. And I think that is absolutely at the sort of centre of what we're doing. So we're under no illusions that people are already doing a huge amount of work on a daily basis, doing improvement work on a daily basis. But hopefully that's helpful in terms of where we're up to in terms of NHS Impact and what the Improvement Board is focusing on going forward. Thank you.
Fantastic, thank you. Sorry, that was to the second. I know I'm slightly obsessed with this, but it was brilliant. Thank you. Mike Bracken, over to you.
Thanks, Samira. Hello, I'll get cracking. I've only got 5 minutes. I'm Mike Bracken from Public Digital. Hello. I come in peace, and I'm not a health person. So, you know, if you're going to throw tomatoes, take them out of tins first and all that. Let me introduce myself. Why am I here? I work at Public Digital. We're a consultancy around the world. We help big organisations around the world, very, very large organisations around the world. These are some of them, and we work very closely with NHS providers. These are some of the things that we do. I won't read the slides to you. I've just come from the sort of global tech thinkers for the European AI bill, so full of that at the moment. But an awful lot of our work is spent with NHS boards around the country. This is my colleague Chris. I can't see him. I can't see anything because of these lights, but he's there somewhere. Please do say hello. But we've been doing an awful lot of work with NHS boards around the world. I'm very humbled by an awful lot of the things I've seen or and learned. You might wonder why I'm here. Our Public Digital largely was formed by a lot of the people that created gov.uk, the Government Digital Service, and have a 25-year background in technology and big system and organisation change before that. Right. How's that? Oh, not bad. Right. We have a problem around the world, and what I'm here to do is one thing is to instill confidence that many of the things that you all talk to me about can actually be changed and solved. Every conversation I have with pretty everyone here says, you don't understand our complexity. You're correct, I don't, but I have that conversation with everybody else in every other industry around the world. You won't be far happy to know that this is not unique. In Canada, this is Phoenix, big IT system, can't pay their own public sector workers, have put billions into that. That's been going on for 10 years. Centrelink Australia, that's ended up in court. Thousands of people have put in jail and having to pay the government back money because it couldn't run its own health security systems. You have, of course, seen around the world various systems and services failing to respond to COVID. The Government Digital Service, which I helped create, was in part a response to the failed NHS programmes in the late stage of the Labour government. We then helped, and I helped the US government set up the US Digital Service as a response to healthcare.gov, which had also gone wrong. Big systems not giving great outcomes, particularly in health and related things around the world, isn't new news. There's not enough research on this, but if you look at the Standish Group report, they have a thing called the Chaos Report, they'll show you that in average, 13% of large government software projects are successful. 13%. which raises the question, why do we keep, and it's got better, I think it's at 17 now, but why do we keep doing things that fail 83% of the time? I recognise success and failure is a false binary, but by and large, we keep doing this. Something's happening around the world that possibly points us in a new way. I don't know if anyone knows what Aadhaar is here. Aadhaar is the Indian system, or if you've seen people voting with the purple thumbs, that's Aadhaar. It's a set of protocols that allows people to vote, to recognise themselves with the state. 400 million people into the formal economy and voting. An enormous, it's not a system, it's an interoperable set of frameworks and protocols that run and are adopted by everyone. It has transformed, I think, large parts of India. It has some downsides as well, but just giving you an idea that there's a different way of thinking about how we provide service. We've been doing this a long time in the south, in many other places. DHS2 is a health system used in South Africa. Navisi, the government of Togo's response to COVID was absolutely astonishing, having a digital-first currency in the hand of female head of households within 18 days, plus health information. It knocks our efforts in developed countries into the shade. We have these sorts of approaches in our midst here. So one of the things we did in the government was set up Notify. Has anyone used Notify? Just about see you? Anyone knows what it is? There's loads and loads of hospital trusts using it. Notify is a thing that allows you to sell notifications, texts and letters and so on. It's run centrally. It's a program. It was basically created as a need because a lot of government officials need to send lots of texts and things to various other people. And we run that centrally as a platform. It's an open platform. Various providers can play. It doesn't pick what winners, and it develops along with user needs. We now have thousands of organisations, many health trusts using it. It's now used in these countries around the world. It's used billions of times. And the question really is, why aren't we doing more of this? Like we did Notify, I think,
just so you know, you've had 5 minutes, so you've got a couple more.
I'm done.
Thank you.
This has been used around the world. We already have these things sort of in our midst, like OpenEHR, OpenAir. These are emergent protocols. Not sure how easy it is for you to use these things. I guess I've come today to really talk about what I see in all systems and all big issue countries around the world is the outcomes that we talk about are really dependent on having user-driven data practices that then are designed into these things rather than procured. It seems to me that if we want to adopt that at scale, we need to think about some bold moves. And these are some of those bold moves there. So as an agent of, I don't know, an agent provocateur, I'll leave you with this slide, but I hope that can help us have a debate later. I don't think it's easy, but it is doable. Thanks very much.
Fantastic. Thank you, Mike. Right, Penny, over to you.
Thank you. Thank you. I'm going to talk about how to make improvement approaches mainstream. I'm guessing it's a priority for everyone in the room to see their organisations innovate and improve to find high quality, high value care. Not just in the way that might be true of any meeting of kind of senior leaders in an industry. Surely if we think about the number of NHS years of service in the room, there can be few sectors where people that are so at the heart of the people who serve those industry. And we know the science and the method of how to go about making services better. And we have those skills in at least pockets in every bit of the health service. The key community that I lead has over 5,000 people who are collaborating to improve the quality and safety of care across the UK and Ireland. So we have some will, we have some skills, and we have the policy intent. So as John was saying, NHS Impact sets some big ambitions. NHS England, along with the Health Foundation, has funded Q on a long-term basis since the start. And yet, we're a really long way from systematically understanding and designing services in a user-centred way in the way that Mike talks about. And in many organisations, improvement is still the stuff of kind of projects and initiatives at the fringes of organisations. That's one reason why I would suggest that we're still tackling the kind of same challenges decades later that we've been wrestling with. If we really were to make these methods kind of core business, then we should see a more reliable approach to improving performance. Improvement offers a kind of systematic, collaborative, pragmatic set of approaches for really understanding issues, working with people to implement them, so that what emerges is more likely to sustain and scale. Health Foundation produced a briefing 10 days ago which explored kind of what it would take to make improvement methods mainstream and a supporting guide to the evidence. So what does this tell us about what's really needed to realise the benefits that are being seen in the best places? We cover a number of factors in the briefing. I'll just kind of focus on a couple. Firstly, I think we need to think more widely about where improvement can help. Things have moved on a long time. So if you're thinking that improvement is something that's about small-scale testing in individual services, you need to kind of broaden your view. It's now being used for redesigning pathways, models of care, being used to kind of target and embed technology. And it's not just for long-term work. I think COVID showed us that these are methods that can be used to very effectively solve problems at speed. Given that CQC is showing that a lot of trusts that are rated outstanding have a systematic approach to improvement, there's a lot of interest, understandably, in what's needed to get there. We've been partnering with NHS providers to help them share some learning about trust-wide improvement approaches. Quality management systems is one model that a number of places are using to kind of guide and support that shift. It's something with a long heritage across industries, so there's quite a few different versions out there. I like the way that it's articulated here in Scotland. It's worth looking at the detail. There's just 3 elements that I'd like to draw out. So firstly, if you're going to be serious about embedding improvement approaches, you need to think in an integrated way about the process of actually implementing the improvement fits with your process of planning and then your process of ongoing monitoring and control of quality. And then when we're talking about monitoring, yes, there is a role for quality assurance, so independent checking of processes, but the learning from other sectors suggests that we need to have much more of the balance and emphasis on internal processes of understanding and continually improving services. And then the third element is that when it comes to embedding improvement, I mean, the cultural and the relational aspects are absolutely critical. So leadership, approaches to co-production and relationships. The evaluation of the Virginia Mason Initiative that the Health Foundation funded and was published last year, it helps us kind of understand the mechanics of some of these cultural elements. So this shows a couple of trusts that took part in the programme. And in this analysis, the people are dots and the lines are connections that they found to be useful in their improvement work. And what this helps us understand is that those human flexible connections are really critical. So the trust on the right-hand side, they put particular effort into creating a learning culture, a shared sense of shared purpose, and they produced both more connections, and those connections were more genuinely collaborative, and that seemed to be related to overall performance, whereas the trust on the left, far more fewer connections, and they were more basic and about basic information exchange. Builds on what Margaret was saying earlier. This particularly excites me because I guess in Q I see the kind of scale.
The last couple of
I'm on it. Last slide. It excites me because in Q I see the kind of scale of improvement, ideas and energy that's in the health service. So this is from the independent evaluation of Q using the same methodology. So here about 200 people who helped us design Q in 2015. As you can see at the start, a set of people who knew each other a bit, some people who didn't know anybody, and 2 people who only knew each other. 6 months later, got much greater density and volume of connections. And our independent evaluators showed that over that period, we also saw a statistically significant increase in their skills and confidence around improvement. So we talk a lot in this conference about relationships and connections mattering. This analysis can help us understand why that's the case. I know it's really tough out there. It feels like this is a really difficult time for people to have the resource and time to be able to improve and innovate when we need it the most. I kind of got conscious that I just wanted to end with saying that it's a long-term journey, but there are a lot of people and ideas out there to help. Thanks.
Fantastic. Thank you so much. Right, James.
Thank you. I wanted to start with what it feels like to lead an organisation that is geographically quite large. And Central London Community Healthcare is probably one of the oddest misnomers as a trust because it feels very different when you're standing in Stevenage. We provide services across 11 London boroughs and the county of Hertfordshire, a full range of adult and children's community services. And I think the real benefit of this is our ability to think through how do we understand improvement and change, and how do we embed that within the different places that we work. So as an organisation, we deliver 3.4 million contacts with residents on a yearly basis, 1.7 million of those in people's homes, plus 70,000 rehabilitation bed stays. And therefore, what we've been focusing on is how do we understand our improvement journey? How do we deliver for those residents in the places in which they live? How do we understand our internal and external variability? And what is our effective way of transforming the organisation? What skills do we need, and how are we going to deliver those? Many colleagues in the room will recognise that community services are quite a disparate array of services. There have been inconsistent models of care. At one point, we had 8 different models of community nursing services within the Trust. At times, some of the resources have been random, and the staffing levels not fit for purpose. But as a Trust, we've started to think through how do we manage that as part of our digital journey, our workforce model, our learning culture, and specifically our leadership, and our leadership within the places in which we work. As an organisation, we don't deliver our services across the entirety of the Trust. We've had to make quite a strong decision to embed leadership within those places and allow our leaders to deliver and work with partners. And part of this is a very clear focus on the part of the board, and sometimes quite a challenging position for us to be able to recognise that we are going to make mistakes, that we are going to need to live with a level of variability, and that variability is a positive thing. It's like living with difference. Our real aim has been to try and deliver a level of consistency across the organisation, but to have that entirely place-based. And that might be within the boroughs in which we work, or in the districts or the county. My previous chair was speaking just before, and she made a comment which we've debated a number of times. Sometimes we have needed to be very neat, but we did not need to be tidy, because ultimately we were going to need to be different in every single place. And we've embedded that through a process of shared governance, where our teams come up with what they think that they should do and how they will manage that. But we've augmented that with serious, rapid service reviews. Our speech and language therapy service in particular, a number of colleagues in this room will recognise some of the challenges that we have for children, has had a huge transformation. We have, instead of following a linear process in the way we have seen our children, we have gone through a non-linear process, allowed groupings of interventions, the voluntary sector to be able to provide that, and we support our children by taking them into specialist needs. Ultimately, those service lines have needed to be redesigned, and as leaders, we've had to really challenge some of our preconceptions around workforce models and have those conversations with our regulators. Colleagues will probably recognise that the health visiting services in this country are struggling because of models of care and staffing levels, and we've had to entirely re-look at what the levels of staffing need to be and how we would implement those. And that's been based upon our staff's ability to deliver change and to think through how we would deliver that and what training needs we would need. And it's having a real impact. Last year, we were sitting at an 18% vacancy rate. In real terms today, we are now at 13%. We have turned our year-to-date turnover around from 19% down to 13%. And it's been based upon our engagement with our colleagues. I am proud that 85% of my workforce and my colleagues are women, and that 55% are from the global majority. And we have been discussing with our colleagues, if we are not proud as individuals about the care that we deliver, then we are not doing the right thing. And this is about not just being proud of what we're delivering, but proud of the colleagues who are delivering it on a daily basis. We have set strong targets, but those targets have helped us to deliver significant change.
3 seconds in hand. Very, very much like it. Thank you so much. So I wanted to start by asking each of you a little bit about examples of kind of key learning that you could share with those who are embarking on kind of thinking about improvement. And I wanted to start with you, James, just in following up what you gave the example of speech therapy and how you adopted a non-linear approach, which had transformed your ability to access children. And I know speech therapy is one of the first NHS services that can feel like it buckles under pressure. Can you tell us briefly about what you did?
Yeah, so I'm actually a speech therapist, and it was probably one of the scariest things to actually see caseloads that were increasing, and seriously children who through COVID had potentially lacked development. We recognised that we were never going to find the staff. We pulled our staff together and said, what do we do? How do we manage this? How do we mitigate the developmental challenges? So what we have worked with our local authorities in areas where we're providing those services to have commissioned voluntary sector organisations to provide community communication interventions and to train those voluntary sector colleagues up to identify children with need and then actually make sure that they are getting appropriate services through their child hubs, through their schools, and then identify those children who need to be moved out. At the same time, we've put in a different process for those children who clearly already had communication impairment.
Excellent. Penny, what about you? Is there a particular example you'd like to pick out of something you've observed in your research?
Gosh, there's so many examples that we've seen. I guess I've been really interested at the number of examples where people are working across organisational boundaries. As I say, a few years ago when I first started doing improvement, a lot of work was within individual departments. But now, for example, seeing examples of people working across the mental and physical health divide. So we did a really interesting project with Mind, looking at people who have both kind of long-term back pain and mental health problems, trying to take a much more holistic view of the sorts of services that they need, and then intervening with, say, physiotherapists to make them more comfortable talking about mental health problems that are also kind of interconnected with the physical health problems that people might be presenting with. There's many examples.
And then presumably you're measuring data to show the impact that nature of
Indeed. I mean, you wouldn't do much improvement work without having that focus on measurement. I think we need to realise that, again, as we start to get more into this complex realm of working across systems, finding the right measures and then being able to actually have the data to guide you is more challenging. But nonetheless, it's important.
Fabulous. Mike, any examples you'd like to pick out of really good practice that people here might, like these very concrete examples of things that have worked?
Well, not in the NHS for me, because I don't work in it, but looking around the world, the thing I pick out is I see systems and services around the world this week, looking at the Rwandan tax system, the Argentine driving system that works across 4 countries in Latin America. I could go on and on, do this all the time. And ask, what's the common feature? And the common feature is reasonably small multidisciplinary teams with a very, very strong connection to users, literally watching and seeing what users are doing all the time, and then with the mandate to deliver that at scale. And the speed of delivery, we saw this in COVID, where countries that had multidisciplinary digital teams that empowered to deliver outcomes, health and finance and information, outstripped all the other countries who were still stuck in procurement, requirements capture, and so on and so forth. So, I'm not going to list for this audience loads and loads of systems examples, but there are so many that sort of begs the question, why don't we have more of those here? And
you think it's realistic that the NHS could use some of those and then scale them up? Because obviously the dilemma for the NHS is the scale. You mentioned the 111 service and apps, and one can see why in theory they should work brilliantly, but you had a dilemma in the circumstances in which they're sometimes deployed. And whether they're adequately resourced. I'm just interested in the gap between, say, you gave the example of Togo, which is a very small country, producing something, well, relatively speaking. How far the NHS is equivalent to that, or it is about just starting very small and then scaling it up within an NHS model?
The problem with NHS, it's a good question. The issue in most of these examples is that friction has been removed by empowering a relatively small group of people, could be hundreds, whatever, to deliver something that then everyone uses as mandation. The problem the NHS has got, as far as I can see, is that there's an awful lots of bits of it that are creating an internal friction and dynamic about a set of deliverables back to each other, somewhat forgetting about the user and designing services for users in the way. Now, it's all very well for someone like me to turn up and tell people here, that's easy. But all I can say is I've seen this happen dozens and dozens of institutions around the world, all of them very large. Are some of them as large as the NHS? Probably not. But, you know, they're in the tens of millions. I think like a 10 million to 20 million user base is pretty optimal sizing for digital transformation.
Okay.
Like that's not beyond the realms of the NHS to work in that way.
Thank you. That was great. John.
Yeah, so the organisation I used to lead, when I first started, everyone told me we had a real problem around safety with patients on outpatient follow-up waiting lists. And it's something everyone seemed to sort of be aware of, but we'd never seen sort of tackled. So we started with the data and started looking at it over time and saying what's happening. We drilled into it. And we brought people together from all across the organisation. We had a conversation about it. And I think it was that shift that I think sort of James described, empowering people to say, well, what's going to happen, involving users in it. And we reduced from having 2.8 level 3 harm incidents related to patients lost to follow-up to 0.6 over a 6-month period. It wasn't a sort of high-tech solution. It was, I think, a different approach, certainly from my leadership perspective, of bringing people together, discussing the problem and using the data to drive that discussion about what is going on, where is this happening, is it one clinic, is it across all of them? So that was probably my sort of biggest learning and experience of that.
Great. We've got a couple of good questions that have come in on digitally, and we'll take questions in the auditorium as well, but these are two that I was thinking of. So one is, what's the plan to ensure that the move to digital doesn't further entrench and increase health inequalities, which is something I was thinking of, Mike, because we've seen it with banking, for example, and we see it with the NHS, where some of the people who are most in need are those least likely to have kind of digital access and confidence. Maybe if you want to take that first, but anyone else should absolutely feel free to contribute too.
Yeah, it's a well-meaning but actual unhelpful question.
It's not
well. Really, really unpopular.
All right, you say what, because I think it's a great question.
No, it's a great question, but whenever you look at system reform, there's a group of people that say the sort of, yeah, but what about the edge case? And that's, of course, in health, and of course, it's like, in this country, roughly, it's about 15% of people who are in the digital divide, and roughly, about half of them can't and half won't. That's roughly. We've done loads of research on that when we did gov.uk. And what we decided to do was design for the main use case, make it as simple as possible for most people most of the time, and design services that people actually want to use, and then make provision offline for people that can't do that. And don't try and force fit a digital solution for like the 15%. Now, if you're talking benefits, something that's really complex, messy family details, that number goes up to about 40%. If you're doing basic transactional stuff like driving licenses, it's in the 90%, like 90% people can do them. Health, somewhere in between. So the simple model is design for the main case and then provide provision offline and with people and with other agencies for the people that can't and won't. Don't try and create the sort of digital utopian service, because it never works.
Thank you. Penny, you wanted to come in on this.
Yeah, I mean, I was lucky enough to spend COVID kind of supporting and tracking work that about 50 people across the UK were doing to implement digital online video consultations during the pandemic. And it was fascinating to see how quickly that happened and how quickly, actually, in a different context, people realised that some of the equity implications were transformed, obviously, because there wasn't another option. What I think has been really interesting about that shift is, as we've come out of the pandemic period where there are now other face-to-face options, I don't think that leaders have always made the transition to build on the learning and the progress that was made during COVID around remote consultations, because actually what they need to do, we're learning, is they need to shift, you need to go back around the loop and do the detailed design, which means that people can be confident as clinical teams that actually the needs of all of their patients are being met. And what we're learning is that's not just important because we do need to make sure that we're catering for the needs of everybody in the population we're serving, but we're also realising that unless staff see equity issues addressed, actually they're putting on the brakes and they're wanting to resist all sorts of digital transformations.
Well, speaking about staff equity, I want to go to the next question, if that's okay, which has come in, which I think is very interesting. It's to do with, I think, a couple of the slides that we saw. How do you reconcile with the lack of staff representation in the impact boards, ethnic diversity? Improvement begins with where our staff where staff are starting from, and it's alarming to see such a lack of ethnic diversity in a newly formed board. That struck me.
Yes, I think it's a really fair question and comment. The board has a number of positions which were recruited to. We went through an open, transparent process for that, and then a number of interested parties. One of the things we did as a board was have a conversation at the first meeting, and we did recognise and acknowledge that, and have committed to review and do a piece of work about actually how we are representing the populations we serve and what our approach to representation and co-production is, because a number of the individuals on the board were identified, selected because of their expertise in improvement, but I think it's a really fair question, challenge, and something the board itself did reflect.
Yeah, well, I think the idea that you're commissioning work to look at why, but actually I think a lot of people would be a bit surprised that it wasn't just something that was addressed in setting up the board. I don't know if anyone else wants to add about this issue. We could take questions from the auditorium then, if we've got arms. Yes, I can see in red. And then I'll try and wave around from there too, because you're further away from me and I'm trying to make sure I get the whole room. Go for it.
Yeah, so just wanted to follow up on
And just
that.
remind us for those, I know you asked a question this morning, did you?
Yes, Janine LaRosa, Chief People Officer at BHRUT. And thank you very much, Samira, for asking the question about the board diversity, because I put that in. But I did want to follow up, because I think we were just having a chat just here in our chairs. What would be really wonderful, and I know you're going to look at it, but I think there's something about us being really explicit about our intent. So I would really be keen to encourage, as we think about diversity, us stating an explicit goal. So in the way that we talk about the 19% representation, for example, goal that we were working to for so long. I would really, I don't want to push you here, but I think just would you be willing to go away and look at, well, what would representation in that board look like?
And actually put a number on it. Thank you. Yes, if you want to do
from an organisational point of view, we have a board metric on representation, and it is challenging because our board doesn't move particularly that much, but we have been doing that, and I would agree, having the metric there and actually focusing on it and being really clear about what you're trying to achieve, and really then thinking through biases, both conscious and unconscious, is helpful in driving that target. And for the first time this year, apart from 8B and 8C, you are more likely to be promoted in my organisation, reflective of the population than not.
Thank you. Right, does anyone else want to come in on this? Yes, go ahead, John.
Yeah, so I think that is a really great suggestion. I'm really happy to have a conversation offline about it, because I think it is something that, as I say, as a board, we absolutely acknowledged. So really happy to take that away and consider it's a very fair and valid point. So thank you for raising it.
And I know there's a question here, and then have you got a question over here? I'm desperate to get this side of the room. Right, go ahead.
I'm not going to ask a question. I'm just going to say my board...
Just remind us again.
Yeah, we're going to be very quick, that's why. I'm just going to make an offer of help. If you look at Coventry-Warwickshire Partnership Board, it is diverse. It is not difficult to recruit people from diverse backgrounds. The talent is out there.
Thank you. Do we have other questions in the room? Otherwise, I've got another one online. So this says, is the rollout of US EPR systems going to repeat the problems of the past, and does it need a new approach? Sounds like one for you, Mike.
Yes and yes.
Right. And can you, for me, as the definite layperson in the room, remind me, what is a US EPR system?
Electronic patient records, they are, by and large parts of enterprise software that hospitals use and other places use to manage the administration and the digitisation of things like your patient record. And it's an oligopoly. I think there are 4 very large providers. When I was in government, and I've got to be reasonably cautious, but when I was in government, the ministers of various types would say to me, why don't you take GDS into health? And I'd say, because we have this problem, like none of the hospitals recognise you when you turn up if you're outside of your local area. And I said, well, it's easy. Put a statutory instrument in and just make them all work to an interoperable standard. Oh, we can't possibly do that. That is, I think, as reasonable a suggestion as it was 10 years ago. Today, I don't know why we don't do that. There's nothing wrong with software being provided by third parties, but we as a country, I think, should recognise that things like EPRs are a part of our national infrastructure. They're as important as the West Coast Main Line or whatever. We should need to think about them in that way, not think about them as procured software that then we are stuck with, and frankly we have to train people to use often software that doesn't meet their needs. We need to be able to think much more differently about things like EPRs, and that starts in the Treasury, and it starts with a different way of thinking about, not thinking about procurement, but thinking about user needs and how you link this stuff together. I've not got any axe to grind with that lot. It's just that for the health service, we could do so much better.
Is it partly a misreporting, dare I say it, by the media? I was thinking about things like, Future Health and Biobank, where there's a news story recently saying that data that patients were giving to Future Health was being used commercially. And there is this slight obsession, I think, in this country about NHS data and people profiting from it. I know there was an issue with Google's partnerships and things. What's your view on how far we're misunderstanding?
Well, that's not necessarily an EPR issue. That's essentially data management.
Yeah.
It's complex, but the issues of data and personal agency over data is one that I don't think we've had a proper conversation politically about in this country. I don't think generally most people understand what is theirs, what is private, and what is actually belongs to the state, and what therefore we can do about it.
But I guess, and this is for the others too, if we're talking about improvement, one of the things we've already seen is when bringing in outside expertise or outside subcontractors in a way, whether that can help the NHS find a new way forward. And I wonder, is there something around the use of data which is part of this conversation now? You want to go on?
There is. Go on. Basically, there's loads of context to that. We've not got time to do it. But basically, the first conversation is, if you're bringing people in, are you bringing them on a rent-seeking engagement where they control something and you're actually paying them to run it? Or are you bringing them to help you run it, where you're setting the standards and parameters around data? And it's got to be the latter if we're going to give people agency over their own data. And we can't do that at the moment with the hodgepodge of different software and the different data processes that we have.
Penny next. And then
I mean, there's obviously issues with the availability of data and where that comes from and all of the issues that we've touched on. I guess I would say that it's also a gap in terms of analytical capacity. So we're awash with lots of data that we're not using well, partly because our analysts are absorbed on kind of high stakes performance management. So if the kind of currency of leadership is data, at the moment we have a slightly dysfunctional system where we're feeding that data up and down the system instead of our analytical capability and our data being used principally to support people as close to the front line as possible to understand their service users and then to iteratively improve. It's partly an issue of the availability of data, but to me it's at least as much about what we're actually doing with it.
James.
And that data, I think we all recognise, is derived out of those EPRs. And my colleague said to me the other day, what are we going to do about our own digital literacy? So it's not just the digital literacy of the population. Our NHS workforce is part of the population, and therefore I think we really need to think through that digital literacy and the way the systems are created, because some of them were created 15 years ago and they really are not fit for purpose.
Did you want to add anything to this, John? No. That's fine. Right, we could take another question also from the hall. Have we got one? Otherwise, I was going to follow up. So it was actually a question for you, John. How can, well, maybe it's for all of you, I mean, regulators are such an important part of how the NHS tries to measure success and improvement. And I wonder how they can best support providers to improve and innovate, because we know there's always a risk, isn't there, with innovation. If you want to go first on this, John.
So I think it's a really good question. I think there's two different mental models here around improvement and about innovation. And I think we often talk as if they're really interchangeable, and I think it's really important that we understand, I think, the difference and what needs to happen in order for that to be true. So I think we've focused very heavily around the improvement space, about what we can do with our existing assets, how we can maximise the benefit of that. And I think we're sometimes less clear and I think recognise less the space and the skills that are needed around innovation. I think the role of the regulator needs to be a supportive one, rather than saying our role is just a blunt instrument to say yes or no. I think it is about engaging with people and understanding what needs to be true in order to make these changes happen to deliver better services for patients, frontline staff.
Ready to get everyone's closing thoughts on this issue. Go ahead, James.
So I would agree. I think if we look at our rating scale with the CQC, it requires improvement or good. But that kind of infers that you require to be improved. But what if you are improving? How inspirational can we be by the use of our language? And I'm going to channel being a speech therapist. If you say to a colleague, you require improvement, or you are improving, They are two very different things.
Very good. Penny.
Yeah, but building on that, I think the regulators need to know what good looks like in terms of improvement. I think what's in the well-led domain, for example, for CQC, aligns pretty well with the evidence base around improvement, but then is the experience of inspection teams actually really understanding the complexity of what that means. And are they sensitive to some of the leadership tensions that are associated with improvement? I mean, for example, being able to meet short-term goals while also keeping an eye on the long term. I would say that at its most negative, some of the regulator performance, emphasis can just drive a short-term focus in a way that saps the energy and some of the longer-term work that needs to happen in organisations.
Thank you. Mike.
Digitise a regulator. In every sector I work in, where there is a more digitised regulator, the sector makes strides quicker. I wish I'd been in government, I'd helped the CQC with more of its internal digitisation to therefore help it have a better...
Can you explain when you're saying more digitised, what would we have seen in a regulator if they'd been better digitised?
Their own processes are digital. Far too many regulators spend a lot of time and effort forcing analogue processes on the organisations that they are regulating. So can you go around and check this and tick this box and so on. Many of the systems and processes, many of the outcomes that they're looking at, they're often checking the wrong... They're often not seeing the waste in the system. So did something get done is a binary thing that you can check. Was it done well, efficiently, could it have been done better is not often being checked. So outcomes-based regulators using digital services, I look at the success in finance of that approach. We had COVID, we had an economic crisis. Yeah. Banks didn't lack liquidity. We have outcome-based regulations. Stephen Bailey's done that very well, I think, in finance. That's a big picture. I wish we had more regulators of various sectors, that they themselves had more digital chops inside them.
Can I just say thank you so much. I can't believe how much ground you've all covered. So we're going from the kind of macro to the micro and back again. So a really terrific session. Thank you all very much indeed. So again, we'd love to have your feedback on this session. Do follow the instructions shown on the screen. There's a QR code you can use. And NHS Providers is committed to supporting members to lead for improvement. And we'd like to mention that there's a programme currently being delivered in partnership with Q Community, the Provider Collaborative's Improving Equitably programme. And we'd also like to let you know about a conference NHS providers are holding next year, focusing on improvement and the wider quality agenda. And it's on May the 23rd, 2024. So do come along, speak to the team on the NHS Providers stand if you'd like further information, and they'll let you know in due course once booking opens for that event. So that brings us to the end of the main sessions, the first day of the conference. I hope you'll agree with me. It's been really fruitful and so many interesting, varied sessions. We heard from Julian Hartley this morning about achievements in the provider sector, Margaret Heffernan discussing key leadership challenges facing NHS provider organisations, the challenge of willful blindness. And we've just had the second of two interesting panel discussions looking at achieving sustainable and equitable recovery of care backlogs. That was this morning. And just now, how we can embed a culture of improvement and innovation. I'd very much encourage you to join the drinks reception, which is taking place from the NHS provider stand. It starts in just a few minutes. We've timed it very nice. You can segue into that. And we'll also look forward to seeing those of you who've booked onto the conference dinner, which takes place from 7 p.m, and that's next door to the exhibition hall. And a reminder that there are 2 breakfast sessions taking place at 8 a.m. tomorrow, so plan your evening carefully, and I'd encourage you to attend. The first one is on how enhanced system visibility is helping to enable transformation at place and improved outcomes for people in Leeds. And that's run by Newton. And the second session is on how do we shift from the current disjointed silo model of healthcare to fully integrated community healthcare. And that's supported by the National Association of Primary Care. So that's the breakfast sessions. We're then back in this room at 9 o'clock tomorrow morning for more thought-provoking discussions and keynotes from, well, we'll definitely be hearing from the new Secretary of State for Health and Social Care, and from Amanda Pritchard and the Shadow Secretary of State. And you'll receive an email roundup capturing the key topics from the day, which we hope you'll find will be a useful summary. Finally, thank you for taking part in today's debates. I hope you'll have a great evening and great breakfast meetings, and I'll see you back in here at 9 o'clock tomorrow. Thank you.